And we are live. So Senate Health and Welfare, we're back. And we're looking again at H 72, the overdose protection sites or centers. And so thank you all for being here. We have Ray Gardner on Zoom. Bring him in. Good morning.
Good morning.
So thank you for being here, and we look forward to your testimony on H 72. We have taken some testimony already. It would be great to hear your thoughts. For about 10 minutes would be great, 10 or 12. And I know there's more than that in your mind, but it would be very helpful to get some very direct testimony on the bill.
Thank you so much, Madam Chair. I do have plenty that I would like to say. I will try to submit extended remarks for the record later today.
That would be terrific.
So I'll try to be as concise as I can. And I do have some slides I'd like to share if
Yep.
that's okay
Perfect.
with me. It's not extensive, but I hope it'll be somewhat helpful.
Yep.
Is that visible?
They're great.
Thank you. Again, thank you, committee members. Thank you, Chair Lyons. I'm Greg Gardner. I serve as a senior policy counsel for the Drug Policy Alliance, commonly referred to as DPA. DPA, as I think most of you know, it's we testified before you in the committee in the past and worked with you many times over the years. But we, as you know, are the leading organization working to eliminate drug policies that cause harm to individuals and communities, and to replace them with evidence-based policies grounded in health, equity, and human rights. I think I want to start out with the fact that overdose prevention centers, or OPCs, are not radical, they're not unusual, and they're not unlawful. They're a reality throughout the world, and I think this has been expressed in previous testimony, but they're in nearly 200 locations across 14 countries, dozens operating across the Canadian provinces and territories. And as Brandon Marshall and Alex Kroll really explained in detail last week, OPCs are incredibly effective in saving lives, reducing infections, reducing emergency response costs, connecting people to an array of supportive services that help promote stability and build bridges to treatment and recovery. And they benefit the community by reducing public use and improperly discarded materials and actually enhancing the public safety. What I found particularly striking in Dr. Kroll's testimony was the comment that the studies have found uniformly positive benefits from OPCs. And particularly striking, I think, was the fact that he said that no peer-reviewed study has found any negative impact of OPCs. You've heard, I think, a fair amount about OnPoint. In just over 2 years in New York City, we've really seen the effectiveness that was described by Dr. Kroll and Dr. Marshall, clearly demonstrated by the 2 sites that they are operating in New York, in Manhattan, which aren't just providing supervised consumption, as I think you know, as I think Dr. Small discussed several weeks ago. These are really serving as health and wellness hubs for people, meaning they're providing just an array of services and programs under one roof. And I think there's been a lot of testimony about those successes and about the thoughtful approach that Rhode Island has been taking over the past 5 years. In 2021, actually enact the legislation. They studied before that the potential impacts of harm reduction centers. They created the legislation. They went through a regulatory process, and then they actually went through the process of funding those through settlement funds, and are set to open the first harm reduction center that has supervised consumption incorporated later this year. They have a site, and as Dr. Marshall mentioned, it's sited near a medical facility, a primary medical facility. So today in my testimony, I've gone through this a little bit, but I want to just focus on the broad support across the country for OPCs for authorizing something similar to what Rhode Island has done, and envisioning facilities that are similar to what OnPoint is really creating and has been an inspiration for people all over the country. I also want to try to address very quickly some of the questions, and certainly I'll do this in my more extended testimony, but address some of the questions and concerns that have come up during this debate and the discussion. Questions like, is this something that makes sense for a state like Vermont? Is this a good use of resources? Are there legal obstacles to doing this? And, the short answer to that is certainly makes sense. It's desperately needed. It's tremendously cost effective. And there's no clear legal barrier preventing a state like Rhode Island or Vermont from moving forward on this now to save lives. I know you talk about this a lot in this committee, and it's an incredibly important topic, but Vermont continues to be in a severe health crisis. And I know you probably look at this graph all of the time, but this is regularly posted in the Department of Health's reports, monthly reports. Dr. Marshall mentioned it previously. I'm showing the graph on fatal drug poisonings dating back to 2010, and I think it's important to recognize the continued rise in the loss of life over the past decade, particularly in the past 8 years. Back in 2014, we considered this an epidemic because at that point, fatalities had doubled in the previous 5 years. But since then, in the years following 2014, we've seen 1,500 Vermonters die from drug poisoning. And in just the past 3 years, we've seen record levels. So whether those numbers are continuing to rise this year or leveling off or maybe even just nominally decreasing, I think it's hard to overstate the urgency, the continuing imminent emergency that this presents. And so I just want to frame the discussion around, or refocus continue to focus, I guess, the discussion around that issue, because I think that anyone that sort of considers or thinks that the existing approach that we're doing is saving lives, is working, may not be receiving complete information. There's way more that needs to be done. This is a situation that calls for new approaches, more resources, more emergency efforts to look for every way possible to reach the people who are at risk. So I just want to jump in and talk about sort of this gap in the continuum of care that exists. Vermont has clearly been on the leading edge of a lot of drug policy reforms over the years, and we recognize and appreciate that. We think, certainly a lot of the leadership on that has come from this committee and others in the legislature. Syringe service programs, developing a hub and spoke treatment model, methadone access, naloxone access, removing criminal penalties for low-level possession of buprenorphine. Last year, passing one of the first comprehensive community-based drug checking laws in the country. And much of this work has really centered around harm reduction. Harm reduction is recognizing and acknowledging that there are people in the community who are not ready for treatment for many reasons. Maybe they think they don't need it. There are many other reasons. And I think, Dakota Roberts may have mentioned some of those as well. But, some have been to treatment many times. And sometimes, in some cases, felt stigmatized and even further marginalized. So there are a lot of reasons that people may be in active use and may not be actively ready for treatment. But harm reduction is an approach focused on helping people who may continue to engage in high-risk practices, explore techniques and strategies for keeping themselves and their community safer. We often talk about meeting people where they are, and that's critically important. I heard it mentioned recently that the state's strategy to address the overdose crisis is built on 4 pillars. That's not what I'm showing in the slide here, but what was mentioned was prevention, treatment, recovery, and enforcement. And I know that this committee has focused on the need for harm reduction extensively. But I think it's important to elevate harm reduction and center it as a central and equally important part of any strategy. I think it is precisely this gap between prevention and treatment when people are not ready, where people are in active use, that is a gap that we need to fill. That's where people are falling through the cracks. We have some incredible organizations in Vermont who are providing really innovative treatment and recovery services. We also have some amazing harm reduction service providers who are doing just this heroic work on really tight budgets to connect with people in the community who are in active use. And yet, those harm reduction organizations, I think to a certain extent, they can only go so far. They can't be there at the time that a person is actually using a substance. They can't monitor that use in a clean space. They can't ensure that there's sterile equipment at the time of use, urge safer ways to ingest, and most importantly, perhaps, jump in at that moment that something goes wrong, the first sign of an emergency. So I think it's clear that, this is a solution that is that it's better to fill that gap in the continuum of care if we can, and that's exactly what the OPC model does. It's surrounding people who use drugs with support and no judgment, no shame, no demand for abstinence, but slowly building trust with people in a way that does build a bridge to treatment and recovery in the future. I think in the past 5 years, we've really seen an incredible change in just sort of the landscape around overdose prevention centers across the country. Leading health organizations, including organizations representing treatment professionals, are supporting states moving forward to enact pilot projects like Rhode Island's. Notably, the American Medical Association, the American Society of Addiction Medicine, the American Academy of Family Physicians have all adopted policies in recent years that recognize the value and effectiveness of OPCs as a harm reduction strategy. EMERSA, many others. And there's been extensive, to my knowledge, letters of support for OPCs expressed to this committee from, national and from many organizations, public health interests, faith-based groups, housing, homeless organizations, current and former law enforcement professionals, prosecutors, businesses, civil rights advocates, many others. And notably, I think there are a lot of treatment and recovery professionals, doctors, who are sending letters to the committee saying that this is something that we desperately need. There are hundreds of others who are signing, community open letter in support of this. I'll jump ahead, but Mr. Roberts and Ms. Kirby, Jess Kirby, really talked about this, I think, in more depth. And so I won't go as deep on this issue, but one of the biggest problems that we face in Vermont and throughout the country is that too many people are using substances alone. So if we're serious about reducing fatalities in the most impactful way, we have to prioritize helping people who are actively using drugs actually not use alone. In recent years, I think, the health department's approach has been to make statements and put out documents, and this is incredibly important, but they are urging people to not use alone. But the problem is, that message kind of gets lost to some extent when we're not saying, here's a place where you can go, where there are people you can trust to help. Sorry, I'm skipping ahead through some of the slides, but some of the organizations I'm showing now, some of the organizations that I know of that have reached out to the committee in support. But in terms of in terms of the issue of people using a loan in Vermont, Dr. Marshall showed this slide, but I want to bring it up again. The vast majority of people who overdose, who have experienced a fatal overdose in Vermont, have no bystander present at the time of the fatal overdose. You know, the most recent social autopsy information that we have from the Department of Health is the 2021 report that showed 41% of the fatalities, the individuals who experienced a fatal overdose didn't have anyone present at the time. They didn't have anyone there at the time when first responders arrived. 41% is incredible, but you add on top of that, you know, the 27% where we don't know. And I think in most of those cases, if someone was there originally, there's a strong likelihood that they were either too afraid, not equipped to do anything, or just didn't know what to do. And I think that tragedy, that incredible tragedy, is that most people who overdosed didn't have a bystander present who was going to do anything. And that's what this bill is really about. Instead of just telling people that they shouldn't use a loan, we should support making spaces where they can feel actually welcomed, actually surrounded by people who are trying to look out for them, offering support, providing basic medical care, showers, laundry, and treated with dignity and respect throughout the entire process. To me, that is a pragmatic approach. It is not radical in any way. It builds trust, connections, it saves taxpayer money in the long run. And increasingly, we're seeing support from even law enforcement in places where OPCs are in effect. Vancouver, New York City, law enforcement tend to be supportive of the centers from what we are told. And speaking to On Point, a senior chief in the NYPD said, "I've been in this business for a long time. Maybe 5 years from now, we will be reacting to OPCs like we do safe syringe exchanges. That's where we're heading. It's going to be a no-brainer shortly." You know, there's been a lot of interest from around the country, you know, hundreds of people streaming through On Point to see their model, to learn more, and to trying to replicate that. And I think there is reason to believe that Chief Tobin is right here, that in 5 years, it's going to be a no-brainer, even in the United States.
So Gray, I think I'm going to ask you to wrap up your testimony. We have two other folks
Of course.
waiting in the wings, and then we do have a hard stop for this at 11:30 because we have a fiscal note coming in.
Of course.
Yeah.
If I could just mention one brief thing about, you know, one of the concerns that's raised.
That would be good. Yeah.
Thank you so much. I will elaborate this much more in the written testimony, but one of the biggest concerns I think is raised, well, certainly people raise the issue of, you know, will this work in a rural state? Certainly will. Is this a good use of resources? It certainly is. But this issue of whether or not it's legal, you know, there are people that just sort of offhand say that it's not legal to do this at the federal level. And that's just not an accurate or precise statement. You know, the reason people say that is because there's this federal statute that you know, prevents 21 USC 856 that makes it unlawful to lease or rent or use or maintain a space for the purpose of manufacturing, distributing, or using a controlled substance. And, you know, most legal scholars, a lot of law enforcement leaders, there are a lot of people who have said that that doesn't apply to OPCs, that's not something that prohibits opening
So Gray, I'm going to ask you to, if you please could put that into your written testimony. Because I think it is very helpful to have this information.
Absolutely.
It's significant to understanding what we can do.
Absolutely. I really appreciate that, and I will go into more depth on that in the written testimony. I'll just show, I scrolled through a couple of slides really quickly, and I do just want to mention that, State's Attorney Donovan was one of the signers supporting the position of the safe house in the Third Circuit several years ago. This is something that I think we're in a good position to go forward on across the country. I have a slide here for additional resources. There's so much information available now that we didn't have 5 years ago, and we're in a very clear position to move forward on this. So really appreciate the indulgence of the committee, the opportunity to testify today and to provide information, and happy to answer any questions in the future or today, or provide additional information that may be helpful.
Thank you. Thank you very much, and we may get back to you with your offer. Thanks so much. We'll, yeah, we appreciate your time and the effort you put into the slides, and in particular, the legality of what we're doing is key to understanding. So please do elaborate in your written testimony on that one. Okay, thank you.
Thank you so much.
All right, so we'll move on to Elizabeth Deutsch. Deutsch, is it Deutsch? Dutch? Elizabeth, are you there?
Can you hear me?
Yes, we can. Thank you for being.
Sorry, my Zoom froze while I was waiting. I apologize.
No apology necessary. So welcome, and you can introduce yourself for the record, and then we'll listen to your testimony, and understanding, maybe 10 minutes would be helpful.
Okay, I probably won't take the whole 10 minutes, but I'm also happy to answer any questions as well.
Terrific.
So good morning, and thank you for this opportunity to talk to you about overdose prevention centers. My name is Elizabeth Deutsch. I am speaking to you today as an RN with 28 years of experience, primarily in emergency medicine, labor and delivery, and currently substance use disorder. I am a concerned constituent who works in an opioid treatment program, but I am not here as a representative of the Howard Center. I am the director of nursing and the assistant director of the Howard Center's Chittenden Clinic. The clinic is Vermont's largest hub, and our current census is 928 patients. We see between 150 and 200 patients a day, and we dispense 900 to 1,200 doses of methadone daily. These are patients who have made it into treatment. These patients receive support and assistance. We provide mental health support along with medication-assisted treatment to treat opioid use disorder. Our medical providers are able to provide education on preventing sexually transmitted infections, including HIV. We can help people get access to the wound care they need, and decreasing the burden on the hospital system. Every day, our doctors, nurses, and clinicians help people move away from chaotic drug use. I highlight this work because 70% of the people who died from overdose in Vermont last year had never been in contact with a treatment program. Overdose prevention centers bring people into a safe environment where they can use drugs without the risk of dying. However, that is not the only benefit of OPCs. They also bring people into contact with resources to support moving away from chaotic drug use. People who have utilized OPCs are more likely to get treatment for their opioid use disorder. There are more than 100 OPCs in operation in more than 60 jurisdictions around the world, and no person has died of an overdose in any OPC in more than 30 years of operations. Currently, New York City is operating 2 OPCs. A New York State Health Department feasibility study found that operating 4 OPCs in New York would save up to 130 lives and $7 million in direct healthcare costs per year. I recognize that our population is much smaller than New York City. However, Burlington could save the lives of our neighbors while also seeing a decrease in healthcare spending and lowering the burden on EMS and UVMMC. Last year, Vermont saw, through November, 212 overdose deaths. The Vermont Department of Health information also shows that this is higher than the previous 3-year average. we are seeing an increase in the number of Vermonters dying of a preventable cause. 212 deaths is 212 too many. We cannot do nothing as our friends, neighbors, and fellow Vermonters are dying from a disease that we have evidence-based treatment for. I am imploring you to approve overdose prevention centers and H72.
Is that it?
That's it, my friend.
Wow, that was very clear and appreciated. If you can send us that and we'll put it up on our webpage, send it, Kiki, that would be terrific.
I will.
Thank you very much. Your experience in this area is extremely helpful to us. It's good to hear.
Yeah, I'm happy to take any questions if you have anything about what it's like to work in substance use disorder in the state of Vermont.
Any questions, committee? Okay, we may come back to you. So
I welcome that. Thank you.
terrific, thank you.
Have a great day.
Yes, good. All right, so we'll move on to Grace Keller, who's here. And Grace, thank you. I know you've been here before, and we look forward to hearing your testimony.
Hey, hi, for the record, I'm Grace Keller. Thank you so much for having me. I have been here. I actually was looking at my records, and the first time I testified in the Senate about OPCs was 2016.
Yeah.
So that's one of the things that I want to talk about, but I also wanted to try and keep it fresh because I think you've heard a lot of what I've said before. So, and what's great is that going last, the statistics are there for you. I think we've also seen we're incredibly lucky to have in harm reduction, people are always so generous with their time and their information, and getting to experience what Rhode Island is going through right now. And, you know, their data is the data that Dr. Marshall is doing and collecting is through the NIH. So this is really getting to the point where we're talking about household interventions and data that's really being collected by the federal government. But I mentioned Dr. Marshall. I am a student in the Masters in Public Health program at Brown University. But for those who don't know me, which I don't know if anybody at this point doesn't, but I worked at Howard Center Safe Recovery for 15 years. It's the syringe service program in Burlington. I started the low barrier buprenorphine program. I worked with the legislature to bring Narcan to the state. And at one point, Safe Recovery was distributing close to 90% of the Narcan in the state. I also had a contract with the health department until recently and Howard Center to do overdose prevention trainings. So that's my experience. I'm really happy to answer questions. But one of the things I was looking at last night and this week to talk about is I think we often talk about our concerns about what happens if we have an OPC. And I really want to look at what happens, what's happening because we don't have an OPC. And one of the things that I was looking at is thinking about, what if you were a state, like what is your worst case scenario? And I realized that in Vermont, we are experiencing a vast amount of worst case scenarios, but they're not all being highlighted in one piece. So I just wanted to give, and I try to stay away from too many statistics, but I was even shocked by this, and it takes quite a bit to shock me at this point. So I would think our worst case scenario in a state would be losing our young people. And 61% of the people who died in Vermont were in 2021 were under the age of 44. And 29% of those people who died in 2021 were under the age of 34. So we're losing our young people. That's really what we need to be looking at. Not that I'm over that age. So of course it's not that I value life in different ways, but I'm just saying when we are taking people at the prime of their life, and this is just for overdose, we'll get into endocarditis also and other harms that are taking the lives of people who use drugs. But some people would say that a terrible marker of the state is that we're losing our workforce. And I don't know if everybody saw it in the news this week, but 23% of the people who died in Vermont in 2021 worked in the construction field. That's not 2020. That's not 23% of the people who worked and died of overdose in Vermont. That's 23% of the people who died in Vermont were in the construction field in 2021. And then 12% of the people who died in Vermont of overdose in 2021 were in the food service industry, and 6% were in manufacturing. So for those three industries, we lost 41% of the people who died of overdose in Vermont in 2021 were working in those three industries. That doesn't count. So I think also we often see this as we want to get people back to work. And of course we do, but we're losing people who are working. We're losing people who are doing everything to keep their families together, to keep a roof over their head. And we're losing people who are homeless, and we're losing people, it runs the gamut. But I think when we are seeing statistics that are this compelling, and I know I worked in restaurants for many years, my partner worked in construction for many years. I don't know exactly how they're gathering these statistics, but my guess is they're underreported because those industries really have a lot of people that are not on the books. So this is from the social autopsy. If we know that 41% of people from those three industries are dying, we are losing our workforce to overdose. 41% of the people who died in Vermont were in those three industries. Next, I looked at one of the bad markers, or the markers that you'd worry about in a state, is that we're losing children who were in our state's custody. 92 people were born after 1982 who died of an overdose in 2021 in Vermont. 49% of those were involved in the Department for Children and Family Services Division as children. So almost 50% of the people born after 1982 and 2021 were DCF involved as children. So I'm sorry that these statistics are coming at you, and it's harsh, but I was even surprised by these. The one that really blew me away is that, and I didn't know this, so I don't know if other people do. Forgive me if you do. But overdose is the leading cause of death in perinatal and pregnant mothers in Vermont. So between 2012 and 2023, we lost 12 perinatal women. So these are women that are either pregnant or within a year of giving birth. And then when you look at actually just 2021 to October of 2021 to early 2023, we lost 8 perinatal women, and 7 were to overdose, and 1 was to endocarditis. So we're losing mothers. So when I say like worst case scenario, these to me are just really the worst case scenario. And the last one I'll give is I couldn't find the statistics, but I know of children in Vermont who have lost both of their parents to overdose. So that is what we're dealing with. I can't imagine. I lost my dad to cancer, and everything was exhausted to keep him alive. And that's one of the only pieces I have with that. If there were things that we could have done differently, or things that other states were doing differently, or things that if he was in another country, he would have had access to, I think the trauma would be much more profound. And so when you put it in the context of a child losing both their parents, we can't answer to them right now with what we have going on. And I know that sounds really harsh, but I think it's true. I also can talk about from the workforce perspective that if we break it down, what you need to prevent an overdose is just time and the opportunity to intervene. And that's what overdose prevention centers do. In 2018, I went to Vancouver for an exploratory look at their overdose prevention centers, and with the projected implementation, and we're in 2024 now, so that didn't happen. But what I found so impactful is that if somebody overdoses there, it happens in real time. There's medical staff, there are people around, and they can react. At Safe Recovery, we experienced 23 overdoses when I was there. All but one where somebody brought there in a car, blue and not breathing. We had no idea how long they'd been that way. I think I've talked about it before, but one of the cases that happened was a person who saw their friend overdosed on the side of the road and brought them to Safe Recovery because they couldn't make it through the traffic and they didn't have a phone to traffic. Our building was on the way to the hospital. And I did rescue breathing for 8 minutes. He had a dog, the person had a dog with them, and the dog thought I was hurting him. So he was coming very close to biting my face for almost the entire time. And we administered Narcan. He survived, but only because of luck. And so, really, we have a subset of people that are responding in this way all the time. And that's what's happening absent of an overdose prevention center. And those people also are the people who want to be working with this population, who want to be offering these services. I appreciate that we are talking to everybody and getting everybody's perspective. The harm reduction community is the only community that works with people who are actively using drugs. And that is by design. It's not a secret. It's not anything more than that is our population. Those are our people. And so if somebody who is using that day shows up at a recovery center, they're not admitted to come in to the vast majority of recovery centers in Vermont. They ask you if you've been using that day, if you've even smoked marijuana 7 hours before or had a beer that morning, you can't come in. And so that's okay. I'm not judging that per se. I'm just saying that the population of people that we're talking about, harm reductionists are the expert in. That's who's working with them. That's where you can go in harm reduction, because that unconditional support, you get access to people throughout their lifetime. And the most dangerous times are things like overdose, or things like relapse. And those are times where people use alone, which is what we also know. And for people who who come to Syringe Exchange, who enter those programs, they have long-term relationships. They come to us when they have a baby, or they get a new job, or they have all these great things, but they also come at the time that they tell no one. I mean, I can't tell you how many people that have said, no one knows I'm using besides you. No one knows I've relapsed. So I think that's one thing we really just need to focus on is, yes, we want the perspective of everybody, and but we really need to be focusing on the experts in this particular field. And I appreciate that this committee in particular is one of the committees that I feel like I'm preaching to the choir, and that we don't find it acceptable that we have continued to not do what we need to be doing, to say that there's not enough data. I think we can stop saying that now, and I think hopefully we have, especially when we're inviting people to come give their time from other states and giving us really impactful data, but that's just my opinion. And the last thing I'll talk about quickly is endocarditis. Endocarditis is an infection of the heart. It comes from injection drug use. It comes from other things. And I don't have current statistics. They're hard to find, but I do know that Dr. Leffler and I spoke about it in the news a couple of years ago. And at UVM Medical Center, they had seen, I think, 60 cases that year, and less than 3 of them were under the age of 40. Now, endocarditis is can and often ends in a heart valve replacement. That process is a $600,000 by 218 standards intervention. So we never want to put this in dollar signs, but that's what you're looking at if you can prevent one of those cases. And overdose prevention centers are evidence-based to prevent those cases. We've had people at our office that have had wounds that are literally, you can't cover with 4 hands. And so really, we want to be getting these people in, bringing them to the people who want to be there, and giving our front lines what they need as far as resources to respond to this crisis. So I think I've talked more than I should have, but I'm a little passionate about this. And so I'm available for questions. I'm also available if you ever hear something that doesn't sound right to you, or always feel free to email me if you have any questions. I know that you all have my email. So thank you so much.
Yeah, Grace, thank you so much. A lot in a short period of time, and anything that you could send to us in writing that we can have on our webpage, as in particular, the data and about what's happening.
I mean, I was even surprised. I started doing a deep dive and it was hard not to burst into tears and need anger management all at the same time. It is really devastating. And when we know these things, we should be able to prevent them. It is shameful. So thank you so much for all you all are doing. This is always feels like a home committee. So I
We're
appreciate
glad
it.
you came to visit us and we will probably reach out again, so.
Thank you.
and
Thank you
thanks for-
all. Take care.
Yeah, take care.
Thanks for your hard work.
All right, so, Nolan, see, we're ahead of schedule and you got your time. We are. So
I'll speak really slow.
we'll move right along to, this is 872 and Nolan has some, funding information for us. It should be great.
For the record, Noel Langwell, Drug Fiscal Office, which you guys all get free flowers.
From the Alzheimer's Association. Would you like one?
Sound good.
I think this is one that represents, like, you have Alzheimer's in the family, you're a caretaker, and
Oh, see, I didn't have a full yellow one, sorry.
Sorry, I didn't mean to. Digress.
Flower
We have
discussion.
Flower
more important
discussion.
things to talk about.
Yeah, so, again, for the record, Noel Langwell, the Drug Fiscal Office. I'm here today to talk a little bit more about the evidence-based education and advertising fund. If you recall, it is in the bill. The bill would increase the current rate from 1.75% to 2.25%, which would raise an additional $1.3 million. So my goal today is to talk a little bit about the fund, how much we expect to raise, what is the expense on, and then also kind of with a little bit of overlap or Venn diagramming a little bit with what's in the House budget that will be coming over, because there's some movement of money. So this is kind of really more of a background conversation. So the manufacturer fee is a fee of 1.75% of the previous calendar year's prescription drug spending by DVA based on the manufacturer label order codes as used in the Medicaid rebate program. Now, the reason I think it's so specific is that way they can actually tie actual specific revenues to a specific piece. So it's basically, in short though, it's tied to Medicaid spending on prescription drugs.
There are 4 documents in the folder under your name. Is there one that we should be looking at right now?
Not yet.
Okay,
I'll pull them up as we go.
got it.
But there's a lot, basically in there, I put the fiscal note. I put my issue brief about the evidence-based fund, which I think you probably posted 7 times already. Every time the word evidence-based comes up, it's in a Kiki post. And then I've got a couple of fancy diagrams with lots of numbers on them to confuse you more. I was a joke. So the fees from this are deposited into a special fund called the Evidence-Based Education Advertising Fund. And then money from this fund can only be used for purposes as identified in statute. So that's in the issue brief. I'm not going to go into the specific purposes of that, but if you want to know, it's in the issue brief. So the history of this is that the fee and the fund were both created in Act 80 of 2007. The initial rate when it passed was 0.5%, and then it has increased twice. It increased in 2016 to 1.5%, and then again to 1.75% in 2019. So I thought I might put up a chart quick. So.
Uh-oh. That doesn't sound good.
It's not showing up. Oh, wait, I'm using it wrong. There it goes. Wow, there we go. Oh. All right, and I'll try to blow that up once. I'll put warnings. That was weird.
Thank you.
Okay.
Well, you're a little- Thank
A
you.
lot of weird things.
Oh,
No, I don't know what's
huh,
happening. All right. It is annoying.
it is what it is.
All right, so what I have here is two different.
Do we have this?
Yes.
Yeah, we have.
Okay, so the first chart on the top is meant to just show you the last 3 years spending of the evidence-based education. I gotta come up with a good acronym for this. What the different spending has been for the last 3 years and the estimated for 24. That's the estimated because we're still in that fiscal year, so we're estimating.
Not like ABBA,
EVA,
but that's
Or Eva.
that.
EVA, that's what someone in the House Appropriation keep calling EVA for a second. What are you talking about? So 3.7 million estimated in 24. I don't have the estimated allocation in the budget for fiscal year 25, but I do know that they estimate $3.5 million being spent this year. And then the House bill, to get ahead of myself, does spend another 1.98 out of 5, and I'll explain what they did there. So it'd be if the House bill passes, or if it passes as passed, it would be $5.5 million spent out of the fund this year. Now, that said, if you look at the bottom chart, it gives you a sense of the expenditures and revenues. And the ending balance, that's the 5.2 in the far right bottom corner. That's how much money is estimated to be on the bottom line after taking into consideration revenues and expenditures. So going into fiscal year 25, there was a surplus of $5.2 million in the fund. It is estimated that in fiscal year 25, they'll spend 3.5 million, and we know that we'll get revenues of at least 3.5 million or more based on the history of what's come in, which was 3.8 in 22, 5.3 in 23, and estimated 4.7 in 24. The only risk of it is that we don't know what 25 will be like because it's been a little bit erratic. It was pretty consistent for many years. And then the last couple of years, it's been sort of erratic. And I don't know if it's tied to initiatives with Adiva that it's unknown.
Right, when you say for many years, how many years has it been?
Since 2008, 2007. So, but we do know that there would be at least, I would say, at least 4 million coming in. So the 3.5 in the 25 budget would be covered. So I think in short, my point is that the surplus will be there, even for this new spending. The question becomes substantial, right? Because if we were raising 4.7 each year and we go to 5.5, so there's that concern, but we will know more once we get 25. So the point of this was just to give you a sense of the moving pieces within that fund. Now I'm going to show you another chart, which is a little bit more colorful. Love colorful charts, just have to represent them small.
It's got yellow.
See if I can find this one. Oh, I got it. All right. All right, so this is a chart that several of us in JFO put together. Maria Blair put it together, and then I sort of added. It's a little too much information, but what this is only we were using for the budget. And what this is, what's that?
Which one is it?
This would be the opioid abatement special fund. So I meant to just show you what's happening in the budget with the opioid abatement. But now the budget hasn't even passed the House yet, but I don't expect this particular piece to change. So what I'm showing you here is what the spending for the opioid abatement fund was as per Act 22 last year. And then what the House is planning, and then you can see what the budget recommendations for 25 are for the opioid abatement. And the reason I'm bringing this up is I'm going to tell you what's happening in the budget. So what they are doing in the budget is they're going to take the 1.98 from naloxone out of the Act 22 money from the opioid abatement fund, move that over to the evidence-based fund. And then instead, that frees up dollars to be spent on syringes. So that's what the proposal was. So I just want to show you the moving piece. So this you'll hear again when we hear what's happening with budgets.
So, and do you know, was this a recommendation of the policy committee to do this?
So,
Okay,
yes,
it's usually in the healthcare committee, but now.
Human Services.
Human Services.
Human Services made the request,
Okay.
so appropriations moved money around to
All right.
accommodate that. Right.
These are not on the website.
It should be.
They're channels. Fiscal notice, but not.
They should all be on the website.
We've got it, we've got it.
We got it.
It's
It's
the last one under.
maybe
normal
refresh.
thing. It's opioid abatement fund appropriations.
Got it.
handout.
Got it.
So is that clear? I tried to talk slower. Because I know I can
Yeah,
talk
no,
too
you
fast.
could maybe
sometimes.
just go through one more time, what's here, that would be helpful.
Okay. What am I walking through? Which part? Oh, which part?
This particular
Okay, so what's happening here,
table,
what's happening here, this is showing you the opioid abatement special fund. Top is the appropriation for 24, and that was based on recommendations and requirements as an act of Act 22, which was an act relating to reducing overdoses. And what was happening is that the House appropriations bill would take the 1.98 from the naloxone out of the opioid abatement fund, move it over to the evidence-based advertising fund, which would free up space to be able to do the 1.1 million for syringes out of the opioid abatement fund. So there's a lot of extra information on here, but that's because I didn't want to create a chart. Can't refuse this chart as well. This is what's happening with that.
For the syringe services,
Correct.
the.
So I highlighted in yellow, well, actually that was highlighted for other reasons, but. This chart has a little too much information on it for the purposes of this, but I didn't think it would hurt for you to see the whole picture. Of what's in everything in the fund. And provided them so that you can do side by side. So that's, I think, really where all I really have to say about this.
Can I ask a question?
yeah, no, go ahead.
So the 1.1. Where on this chart is the amount for the overdose prevention sites centers? Oh,
Well, that's not out of the fund.
yeah, I know, but where,
Well, you want to go to the fiscal note?
yeah,
The fiscal note appropriates 2 million. Oh, it does. Oh,
so the opioid abatements,
interesting.
this,
Pilot program, section 6 of the bill is 2 million from the evidence-based education advertising fund.
Oh.
Is that still?
Yeah, the reason it's not on the chart for the evidence base, because I don't have 25 on here.
you don't have,
This is 20,
oh, okay.
right? It's only 24, and the H72 would be 2 million would be in 25. And by the way, the 3.5 million that's in the governor's rec does not include 2 million. That's legislative. So the money's there in the short term, but
It's not gonna be sustained.
not. There's one time things would work.
In the
Evidence.
evidence-based fund.
So, and so I was kind of looking over at Representative Small, was the intent to have this be a one-time appropriation from the?
Well, actually, if I can
will you
answer the
that
question.
one? Okay,
They also had an increase in fee, so there's an additional 1.3 million. So technically that covers syringes, although that's separate. Yeah. But nonetheless, I will let you answer the question about one time or.
Yes, for the record, Representative Taylor Small, our intention was with the increased fee to have it be a sustaining payment for the overdose prevention centers. We knew that it would be a higher upfront cost to get them started, so the recommendation from the community providers was 2.6 million. We of course put 2 million in initially, but expected the ongoing cost to be less than that moving forward.
So then another question, did you look at the opioid settlement fund and as a source, because theoretically, we have heard that these centers will gradually not be required as much. So as the opioid abatement fund goes down, maybe also the need out there will go down. Did you talk about that at all?
We absolutely did talk about it, especially with seeing what Rhode Island had done, but our committee didn't want to preempt the opioid abatement council from their recommendations and putting forward. Since we passed this in January, their recommendations weren't out yet.
Got it.
So we found an additional funding stream to put into this bill. But we're also very excited to see that the council.
Thank you,
supported.
that's really helpful and
Yeah.
it helps us as we're thinking about a good direction to go. But
So I and partly it's because FY 25 is not on here, Nolan, so I'm trying to figure out where could you add FY 25 to this so that I could,
Yeah,
so I can see what
the one thing
the
I,
House recommended versus. I mean, is the House amendment supposed to be FY 24 or 25?
25.
like,
Yes, I can add it. The reason I didn't,
based on the previous year, so based on.
the only reason I didn't add 25 was I didn't know how the breakdown of all the governor's recommended pieces would be for all the other
Okay.
things. So I have the total amount they were spending, but I don't have the total, and I think in one of my charts, I just put, what I should have done, if you look at the exhibit chart, I should have also added 2 million and each 72.
Okay, but I just might need to spend a little bit more time with you and Dean on this, I just wanna, as the opioid, as the representative on the opioid settlement advisory committee, as you probably know, the use of this fund has been, somewhat,
Interesting.
interesting. The committee recommended that the opioid settlement of funds be used for the overdose prevention sites. That was the committee's recommendations. The commissioner, when he wrote his letter, noted that the committee recommended that, but then didn't use the fund, didn't himself recommend that the funds be used because the House had already said they were going to use these other funds. So it was sort of this chicken and egg thing that both of them were doing, in a way. And so it wasn't exactly synced, as well as we might have wanted it to be. But just this Monday, the opioid settlement committee met again, and they're going to write a letter this week, just reiterating that the committee's recommendations are to use the opioid settlement funds for the overdose prevention site.
This is good because my intent is to have. I hope that letter will come to us.
I think it is, it's supposed to, I haven't seen it yet, but it was,
And then we'll have the commissioner come in because I know he had changed he had after the fact, after all of this is going on, I think, said that he would consider this. So we'll have the commissioner in, we'll look at the letter, and then we'll sort out how best to go forward. So this is really helpful to know.
Yeah, I mean, I think that, myself personally, I just want to make sure that we find good funding sources for all the things that we need, and I don't necessarily care so much which funds it comes from, as long as we find the funds for it and that it's a sustainable long-term funding source. And I think, Representative Small was saying that the House was looking for a sustainable long-term funding source, and that's why they increased the
Right,
fee and landed where they landed. The opioid settlement fund is not it is time limited. I think it depends on how we want to look at it, if it's one-time startup fund or if it's supposed to be ongoing operational funds. I just want to make sure that we find something that's stable for the program. And that we're sort of covering all bases. So I will just tell you honestly, you can watch the tape if you want. I was sort of neutral on whether we should send another letter. I was like, it doesn't really matter so much to me where the source of money is, as long as it's a solid, long-term funding source. Either fund could be reasonable.
So we'll get that letter, hopefully.
Yeah, I think it should be,
Okay,
I think early next week, it should be.
perfect timing.
The other thing I will do, send Hardy, I'll put together, a little bit, a better spreadsheet that shows the
Yeah.
ups and downs of all the pieces. I just didn't have time. Because this all came together very quickly.
Yeah.
So I didn't, I just haven't had a chance, but I'll have something a little bit where all the numbers are on one sheet
Okay,
with
that would
revenue
be both the
expenditures.
funds.
Yeah,
Okay,
and then it'll be a little cleaner so that when this I assume this committee will be making recommendations.
Oh, yes.
yeah,
Not just for the bill, but also you have to do it in context of what you do in the bill and how that fits into the budget as well. So
exactly.
I'll have something.
Yeah, and all the other, because one quick thing.
Go ahead.
One of the things that I think is really important that we fund, and I believe the House did, and Rep. Small, you can correct me if I'm wrong, is make sure that we get funding for our syringe service providers.
We did
They,
that.
that what was in the BAA was not sufficient. They need a lot more, and that wasn't in the opioid settlement fund recommendations because we didn't get a request from them. So that needs to be funded because literally people are dumping syringes in the woods because there's not sufficient syringe services. So I want to make sure that whatever we recommend has funding for both things in it. So the two
So
funds.
what we're going to do is we're going to look at everything that's in the budget that relates to us. And we're going to go through that and set our priorities. I do know that the syringe program has been in difficulty, I mean, since January. So we will put all of these things in a bucket and we all have our priorities. And as a committee, we do have our priorities. So we'll do that going forward. And Senator Gulick and Senator Weeks each have a question.
My question was to have Senator Hardy articulate her concerns, but she did that really well, so thank you.
Good. Very good.
So no question.
Yeah, so questions for anybody in the room who can address. So I'm just trying to kind of look a little bit further over the horizon. 2 million, 2 sites, 1 year pilot budget. What's the overall estimate for the number of sites necessary? And then that relates to longer range costs per year. That's question 1. Question 2 is there any anticipated, given the fact that the opioid abatement fund is it's got a limited scope. Is there any conceivable notion on how long these programs would be necessary? And indefinite I think is a bit of a non-answer. I'm just wondering if anybody can address either of those questions.
I'm gonna look at Representative Small and ask, because we will be taking testimony that may fill in the answer for that question, but you've been engaged in this, so why don't you go ahead?
Thank you, Madam Chair. And I think the answer that our committee came to was that 2 sites are appropriate for Vermont and understanding the geographic distances and especially the research that Dr. Brandon Marshall has provided for this committee about folks traveling. We know that folks using OPCs are typically within a walking radius. Folks are not driving there. We're not seeing folks driving across Vermont to go to these places. So recognizing the geographic disparities, we want to ensure that Vermonters have access to those. And to your second question, I wouldn't say indefinitely, but I think what is really helpful in the bill right now is that 4-year study after the implementation of overdose prevention centers. I think having that come back to the legislature will let us know how long these will need to be upstanding in Vermont and whether they are truly having an impact on overdose deaths. I think the assumption, of course, is that they will, and that's why we have the research there to either prove or disprove that.
Good, thank you. Some clarity. then the other thing that we haven't talked about, and we will, is the use of mobile OPCs. So that might actually expand capacity in a different way. Is there anything else we need to know here? Oh, well, we need to know the future. That's what we want. Thank you. This is good. This is start. So we'll drill down into the budget. We'll look at what the two funds have for us. We'll have the Commissioner of Health, and hopefully we'll get the letter from the committee. And then we can start to look at the funding. Well, as we start to walk through and do markup on the bill, this will be very helpful to us. Senator Williams.
For Representative Smalls, did the House look at co-locating the OPCs with recovery sites that would actually cut down on transportation? My concern has always been prevention. Because I had a couple people that came to me about this particular bill and said they had a relative that was being treated at a local hospital. And when he came out, his father picked him up and said, I want you to give me your cell phone. And he was going back to his home, but people who were providing the drugs to him thought he was going back to where he was staying. And he said between the time he left the hospital and got home, he got pinged 5 times by people that were providing the drugs to this individual. So his son really wanted to be cleaned up. And if you had that ability to co-locate OPCs with a recovery site, would it be protected from that? Makes sense.
Yeah, I think that is a really valuable question, and I think the co-location that we put into the bill was around syringe service programs and expanding what services they are already providing. I think the difficulty, as was highlighted by Grace Keller a little bit earlier, is that if we were to co-locate with recovery centers are really focused on an abstinence-based program. And so I worry about triggering folks who are in recovery if there's a place for them to use right next door, but then next door to that is saying you're not using. And just the piece that it is kind of 2 different pillars within the spectrum of addressing the overdose crisis. So harm reduction feels more in line with our syringe service programs, but I think what is really integral is that pathway to treatment. So whether there is a provider in there that is getting them into a recovery center afterwards. So I think it is a both and on that one.
Thank you. So Grace, are you still there?
I am still here.
You had one last thing you wanted to
Yes.
share with us.
And I can answer that quickly too. But I just wanted to say with all of that, I forgot the one really important piece that I meant to say, because it's less compelling to me than the statistics. But what is critical is the inclusion of the language that the Medical Society talked about yesterday around liability protections. As somebody who worked in a syringe service program and in a designated agency, I think you would have a hard time finding any program that would implement an OPC without those protections. And this is modeled after Rhode Island. So luckily we don't have to reinvent the wheel. But I think that those protections really need to be included. They're similar to the protections for drug checking that y'all included last time. And then for Senator Williams, I can be very quick, but syringe service programs, people who use them are 5 times more likely to enter treatment than people who do not. And they found the same thing with OPCs. So I think it's actually the secret to all of that is that it's a great conduit to treatment and recovery, and really working with people. Because the goal for all of these programs is for people to feel healthier, have healthier options, have options that make sense to them and support them through that. So the syringe service programs are really, really effective, and so will the OPC be. Also, I know that one of the concerns is driving, and this is the one time when you actually have an opportunity to intervene. And we have unsafe injection sites all over. I did a training at the Intervale, and people There's no one there that's going to stop somebody who's either struggling with intoxication but at Safe Recovery, we often, not often, because often people don't drive, but we have stopped people. And because of our relationship with them, they say, sure, we offer food, we offer them a cab ride home. As a bartender in my 20s, that was not the case when you tried to stop someone who was drinking from driving. But when you have a long-standing relationship with somebody, you can say, hey, Susie, you seem like you're struggling. Can we get you some food, a sandwich, and sit here with us for a while? Or can we bring you home or a cab ride? And so I think that's one last thing I wanted to say is that OPCs are the reason driving is a reason to do this, to give us an opportunity to intervene rather than not to do it. So those are my last ones. Sorry to filibuster at the end here, but the liability protections are absolutely critical.
Yes, thank you. And we did ask Michelle to bring us suggestions for language that we'll look at when we go to the bill.
Great. Thank you so much. I'm so sorry to come back on.
All right, thank you. So that's a wrap for the day. So we'll go off